Eating disorders are complex conditions that involve both psychological and physiologic consequences. Although they originate as mental health disorders, they can quickly become medical emergencies because of severe nutritional deficiencies and electrolyte imbalances. As practical nurses, it is important to understand both the mental health component and the medical complications. Anorexia nervosa is characterized by refusal to maintain adequate body weight, intense fear of gaining weight, and distorted body image. Patients restrict calories severely and may exercise excessively. Although classified as a psychiatric disorder, patients are frequently admitted to medical units for complications such as dehydration, bradycardia, hypotension, hypokalemia, or malnutrition requiring enteral or parenteral nutrition. Long-term treatment requires psychotherapy, nutrition rehabilitation, and behavior modification. Bulimia nervosa involves recurrent binge eating followed by compensatory behaviors such as self-induced vomiting, laxative misuse, excessive exercise, or diuretic use. Frequent purging leads to metabolic alkalosis, hypokalemia, dental enamel erosion, esophagitis, and potential cardiac dysrhythmias. Treatment includes psychotherapy, antidepressant medications such as selective serotonin reuptake inhibitors, and nutritional counseling. Both disorders require a multidisciplinary approach and careful monitoring of laboratory values, hydration status, and cardiac rhythm. Obesity is defined using body mass index, or BMI. A BMI of 30 or greater is classified as obese. Obesity is now recognized as a chronic disease by the American Medical Association. It significantly increases risk for cardiovascular disease, type 2 diabetes, hypertension, hyperlipidemia, obstructive sleep apnea, certain cancers, osteoarthritis, and gallbladder disease. Obesity results from a complex interaction of genetic predisposition, environmental influences, dietary patterns, sedentary lifestyle, medications, and psychological factors. Excess caloric intake combined with reduced energy expenditure leads to fat accumulation. Family lifestyle patterns often play a strong role. Severe or morbid obesity is defined as a BMI greater than 40 or approximately 100% above ideal body weight. Central obesity, measured using waist-to-hip ratio, is especially associated with metabolic syndrome and cardiovascular risk. Obesity is diagnosed using BMI, waist circumference, and waist-to-hip ratio. A waist-to-hip ratio above 1.0 in males or 0.8 in females suggests increased health risk. Abdominal fat distribution is more predictive of cardiovascular disease than total body weight alone. Complications of obesity include diabetes, mellitus, hypertension, coronary artery disease, obstructive sleep apnea, cholelithiasis, certain cancers, arthritis, impaired wound healing, and increased susceptibility to infection. Obesity also increases perioperative risk and complicates medication dosing. As nurses, we must approach obesity with sensitivity and avoid stigma. Education should focus on health improvement rather than appearance. We also play a role in monitoring for complications and encouraging preventive care. The foundation of obesity treatment remains dietary modification and physical activity. A thorough health assessment should be completed before beginning a weight reduction program. Caloric reduction must be balanced with adequate nutrition. Behavior modification strategies are essential. Patients benefit from identifying triggers for overeating, learning stress reduction techniques, and developing healthier coping mechanisms. Support groups and structured programs improve long-term success. Pharmacologic therapy may be considered for patients with BMI + 30 or 27 with comorbid conditions. Medications include appetite suppressants, medications that decrease fat absorption such as orlistat, and glucagon-like peptide-1 receptor agonists such as semaglutide and liraglutide. These medications delay gastric emptying, reduce appetite, and improve glycemic control. Bariatric surgery may be indicated for patients with BMI 40 or 35 with serious comorbidities. Surgery requires lifelong dietary changes and monitoring for nutritional deficiencies. Bariatric surgery is a treatment option for obesity when lifestyle changes and medication therapy have not been enough, and when the patient meets guideline-based criteria. Current guidelines published in 2022 recommend bariatric surgery for patients with a body mass index of 35 or greater, even with or without obesity-related complications. Surgery may also be considered for patients with a body mass index of 30 to 34.9 who have metabolic disease, such as type 2 diabetes, because weight reduction can significantly improve metabolic outcomes. Bariatric surgery is not a quick fix. It requires lifelong behavior change, nutrition management, follow-up care, and strong patient education. Preparation for bariatric surgery is done through a multidisciplinary team, which often includes a surgeon, primary provider, dietitian, mental health professional, and nursing staff. The team assesses readiness, provides counseling, teaches postoperative diet progression, and reviews lifestyle changes needed for success. Nurses reinforce realistic expectations, assess for understanding, and identify barriers such as limited health literacy, food insecurity, depression, or poor social support. Bariatric surgeries are generally categorized as restrictive, malabsorptive, or a combination of both. Restrictive procedures reduce the size of the stomach so the patient feels full sooner. The most common restrictive procedure is laparoscopic sleeve gastrectomy. In this surgery, part of the stomach is removed, leaving a narrow sleeve that holds less food. In addition to restriction, removal of stomach tissue decreases the hormone ghrelin, which can reduce appetite. Adjustable gastric banding is another restrictive procedure. A band is placed laparoscopically around the upper portion of the stomach, creating a smaller pouch. The band can be tightened or loosened through a port under the skin. This procedure is done less often today because of complications and less weight loss compared to sleeve gastrectomy and bypass. Malabsorptive and combination procedures reduce stomach size and also decrease nutrient absorption by bypassing part of the small intestine. Roux-en-Y gastric bypass is a common combination procedure. It creates a small stomach pouch and reroutes food past the duodenum and part of the jejunum. This limits calorie absorption and changes gut hormones, which can improve diabetes control. Because part of the intestine is bypassed, this procedure has a higher risk of vitamin and mineral deficiencies than purely restrictive surgeries. Biliopancreatic diversion with a duodenal switch includes a sleeve-type stomach with significant intestinal bypass. This can result in substantial weight loss, but also carries a higher long-term risk of malnutrition, protein deficiency, and fat-soluble vitamin deficiencies if supplementation and follow-up are not consistent. Bariatric surgery is a treatment option for obesity when lifestyle changes and medication therapy have not been enough, and when the patient meets guideline-based criteria. Current guidelines published in 2022 recommend bariatric surgery for patients with a body mass index of 35 or greater, even with or without obesity-related complications. Surgery may also be considered for patients with a body mass index of 30 to 34.9 who have metabolic disease such as type 2 diabetes because weight reduction can significantly improve metabolic outcomes. Bariatric surgery is not a quick fix. It requires lifelong behavior change, nutrition management, follow-up care, and strong patient education. Preparation for bariatric surgery is done through a multidisciplinary team, which often includes a surgeon, primary provider, dietitian, mental health professional, and nursing staff. The team assesses readiness, provides counseling, teaches postoperative diet progression, and reviews lifestyle changes needed for success. Nurses reinforce realistic expectations, assess for understanding, and identify barriers such as limited health literacy, food insecurity, depression, or poor social support. In the image, you can see images of the different bariatric surgical procedures. A shows laparoscopic banding, with the option of a reservoir band and subcutaneous access to restrict the stomach further after the compensatory expansion has occurred. B shows the vertical incision made in a sleeve gastrectomy. C shows the surgical alteration made in a Roux-en-Y gastric bypass. Finally, B shows the alterations and incisions made to the biliopancreatic diversion with duodenal switch. Let's talk about each of these in a bit more detail. Bariatric surgeries are generally categorized as restrictive, malabsorptive, or a combination of both. Restrictive procedures reduce the size of the stomach so the patient feels full sooner. The most common restrictive procedure is laparoscopic sleeve gastrectomy. In this surgery, part of the stomach is removed, leaving a narrow sleeve that holds less food. In addition to restriction, removal of stomach tissue decreases the hormone ghrelin, which can reduce appetite. Adjustable gastric banding is another restrictive procedure. A band is placed laparoscopically around the upper portion of the stomach, creating a smaller pouch. The band can be tightened or loosened through a port under the skin. This procedure is done less often today because of complications and less weight loss compared to sleeve gastrectomy and bypass. Malabsorptive and combination procedures reduce stomach size and also decrease nutrient absorption by bypassing part of the small intestine. Roux-en-Y gastric bypass is a common combination procedure. It creates a small stomach pouch and reroutes food past the duodenum and part of the jejunum. This limits calorie absorption and changes gut hormones, which can improve diabetes control. Because part of the intestine is bypassed, this procedure has a higher risk of vitamin and mineral deficiencies than purely restrictive surgeries. Biliopancreatic diversion with a duodenal switch includes a sleeve-type stomach with significant intestinal bypass. This can result in substantial weight loss, but also carries a higher long-term risk of malnutrition, protein deficiency, and fat-soluble vitamin deficiencies if supplementation and follow-up are not consistent. Complications may occur early or later. In the early postoperative period, one serious complication is leakage of stomach contents into the abdominal cavity, especially after Roux-en-Y gastric bypass. A leak can cause severe infection and sepsis. Warning signs include increasing abdominal pain, fever, tachycardia, nausea and vomiting, hypotension, and signs of shock. If these occur, the nurse must treat this as urgent and notify the provider immediately. Diagnostic tests such as an upper gastrointestinal series or computed tomography scan may be used. Later complications can include stretching of the pouch or breakdown along staple lines, which can also lead to leakage. With some banding procedures, erosion into the stomach wall may occur over time. Roux-en-Y gastric bypass patients are also at risk for dumping syndrome. Dumping occurs when food, especially high-sugar foods, moves too quickly into the small intestine. Early symptoms may include nausea, abdominal cramping, sweating, weakness, dizziness, palpitations, and diarrhea soon after eating. Teaching focuses on eating small meals, avoiding concentrated sweets, choosing higher protein foods, and separating fluids from meals when instructed. Because obesity increases surgical risk, bariatric patients are at higher risk for postoperative respiratory and cardiovascular complications. They are more prone to hypoventilation, atelectasis, and pulmonary embolism due to reduced mobility and increased clot risk. Nursing priorities include early ambulation, use of sequential compression devices, incentive spirometry, pain control that supports deep breathing, and close monitoring for signs of deep vein thrombosis or pulmonary embolism. Rapid weight loss after surgery increases the risk for gallstones, and a significant portion of bariatric patients develop gallstones within months of surgery. Some patients may receive preventive medication, and others may require gallbladder removal if symptoms occur. All bariatric surgery patients are at risk for nutritional deficiencies, and the risk is highest with Roux-en-Y gastric bypass and duodenal switch procedures. Common deficiencies include iron, vitamin B12, calcium, folate, and sometimes fat-soluble vitamins. These deficiencies occur because absorption sites are bypassed and overall intake is reduced. Lifelong vitamin and mineral supplementation and routine laboratory monitoring are required. Dietitian support is essential before and after surgery to guide safe diet progression, adequate protein intake, and long-term nutrient management. For patients undergoing bariatric surgery, preoperative and postoperative care follows general abdominal surgery principles, with additional considerations related to obesity. Equipment such as bariatric beds, lifting devices, and reinforced chairs must be available to prevent staff and patient injury. Postoperative monitoring includes respiratory assessment, early ambulation, venous thromboembolism prevention, and monitoring for surgical complications. After bariatric surgery, diet progression is gradual. Patients typically begin with small amounts of clear liquids, often 1 ounce at a time, then advance to pureed foods, soft foods, and eventually regular textured foods over several weeks. Meals are small and frequent. Protein intake is prioritized to prevent muscle loss. Sugar and concentrated sweets are avoided to reduce the risk of dumping syndrome. Long-term vitamin and mineral supplementation is required, including multivitamins, calcium, vitamin D, iron when indicated, and vitamin B12. Lifelong follow-up is necessary to monitor for deficiencies, anemia, bone loss, and malnutrition. Nursing management of obesity follows the nursing process: assessment, diagnosis, planning, implementation, and evaluation. Obesity is a chronic disease that requires long-term management rather than short-term intervention. As practical nurses, our role includes assessment, patient education, support, monitoring, and reinforcement of healthy lifestyle behaviors. During assessment, data collection includes identifying family history of obesity and determining contributing factors such as dietary habits, physical inactivity, stress, sleep patterns, medications, and socioeconomic influences. A detailed 7-day food and activity record provides valuable insight into caloric intake and patterns, such as emotional eating or late-night snacking. Physical assessment includes measuring weight and height, calculating body mass index, and sometimes measuring skin fold thickness. Waist circumference may also be used to assess central obesity. A general health assessment should evaluate blood pressure, glucose control, lipid levels, mobility limitations, sleep quality, and signs of comorbid conditions such as diabetes or obstructive sleep apnea. Nursing diagnoses may include altered body image, decreased self-esteem, altered mobility, inadequate health management, social isolation, and weight above recommended body mass index. When planning care, goals must be realistic and long-term. Rapid weight loss is neither sustainable nor healthy. Expected outcomes might include increased intake of fruits and vegetables, reduced consumption of high-fat foods, increased physical activity as tolerated, improved self-perception, and demonstrated understanding of the treatment plan. Implementation focuses on individualized lifestyle modification. The diet and exercise plan should reflect the patient's preferences, cultural background, daily routine, and financial resources. Encouraging the patient to keep a food and activity diary increases awareness and accountability. Weekly counseling sessions can provide reinforcement and problem-solving support. Nurses should discourage fad diets and emphasize a balanced, nutrient-dense, calorie-controlled eating pattern. Commercial programs such as structured weight loss groups may offer social support and improve long-term maintenance. Evaluation includes reviewing the patient's food and activity diary, monitoring weight trends, assessing laboratory values, and evaluating progress toward behavioral goals. Weight should be tracked consistently but without promoting obsession. If expected outcomes are not being met, the care plan must be revised. Ongoing group support improves long-term success, particularly for bariatric surgery patients. Stomatitis is a generalized inflammation of the mucous membranes of the mouth. It may result from mechanical irritation such as ill-fitting dentures or malocclusion of the teeth, poor oral hygiene, vitamin deficiencies, especially B-complex vitamins, smoking, alcohol use, infection, chemotherapy, radiation therapy, or certain medications such as anticonvulsants. Common symptoms include pain, redness, swelling, dryness, or excessive salivation, halitosis, and sometimes fever. Patients may have aphthous ulcers, commonly known as canker sores, which appear as small, painful, shallow lesions with a pale center and red border. Treatment is primarily symptomatic unless a specific infection such as candidiasis or herpes simplex virus is identified. Nursing care focuses on gentle but thorough oral hygiene, use of non-alcohol-based mouth rinses, avoidance of irritating foods such as spicy or acidic items, and ensuring adequate hydration. Artificial saliva may help in cases of severe dryness. Nutritional intake must be monitored because pain can reduce oral intake and lead to weight loss. Complementary therapy such as lysine is sometimes used for recurrent aphthous ulcers. However, patients should be reminded that supplements are not regulated the same way as prescription medications and should be discussed with their provider. Dysphagia means difficulty swallowing. It is a symptom rather than a disease and can range from mild discomfort to complete inability to swallow solids or liquids. Causes include esophageal tumors, diverticula, strictures, inflammation, gastroesophageal reflux disease, and neurologic conditions such as stroke, Parkinson's disease, or multiple sclerosis. If a patient is choking or demonstrating signs of swallowing difficulty, the patient should be placed on nothing by mouth status until evaluated. Bedside swallow screening may be performed by a nurse trained in the procedure or by a speech-language pathologist. A modified barium swallow study using video fluoroscopy may be ordered to visualize the swallowing mechanism and identify aspiration risk. Nursing management of dysphagia focuses on safety, adequate nutrition, and aspiration prevention. Before meals, patients may perform practice swallows. The nurse should observe laryngeal elevation during swallowing, which indicates proper airway protection. Patients should sit upright, usually at a 90-degree angle, with the chin slightly tucked unless otherwise directed by a speech therapist. Food consistency is critical. Some patients tolerate thickened liquids better than thin liquids, while others tolerate soft solids more easily. Thin liquids often increase aspiration risk. Thickening agents may be prescribed. Meals should be unhurried and distractions minimized. Patients at risk for aspiration must have oral suction equipment readily available. The Yankauer suction device should be accessible at the bedside. After any choking episode, respiratory status must be closely monitored for signs of aspiration pneumonia, such as cough, fever, shortness of breath, or abnormal lung sounds. Older adults, especially those who have experienced stroke, commonly have dysphagia. Swallowing pills may be difficult. Strategies such as placing the pill on the back of the tongue, using chin tuck positioning, and following with adequate water may help, but crushing medications must only be done if approved by the pharmacy and provider. Neuromuscular electrical stimulation may be used in selected patients to improve swallowing function. Speech therapy exercises such as tongue strengthening, vocal exercises, and controlled swallowing techniques can improve coordination and muscle strength. If oral intake is insufficient or unsafe, enteral feeding through a gastrostomy tube may be necessary. This ensures adequate nutrition while protecting the airway. Cancer of the oral cavity includes cancers of the lips, tongue, floor of the mouth, and other oral tissues. Most oral cancers are squamous cell carcinomas, meaning they start in the thin, flat cells that line the mouth and throat. Oral cancer can be highly treatable when found early, so screening and early reporting of abnormal findings are essential. Major risk factors include cigarette smoking, smokeless tobacco, pipe smoking, and heavy alcohol use, and risk is even higher when tobacco and alcohol are combined. Infection with human papillomavirus HPV, is also associated with some oral and oropharyngeal cancers. A key nursing teaching point is that any sore, lesion, or discoloration in the mouth that does not heal should be evaluated, especially if it persists beyond a couple of weeks. Patients may notice a persistent mouth sore, a lump, red or white patches, bleeding, pain, difficulty chewing, or changes in speech. Leukoplakia is a white patch that cannot be scraped off and can be precancerous, so dental and oral exams should include inspection for these lesions. The mnemonic rule is sometimes used to encourage follow-up, meaning red, ulcerated, or lump-like changes that persist for several weeks should not be ignored. Diagnosis is confirmed by physical examination and biopsy. Treatment depends on location and stage and may include surgery, radiation therapy, and sometimes systemic therapies. More extensive disease may require surgeries such as partial jaw or tongue resections, and if cervical lymph nodes are involved, a neck dissection may be performed. Because airway swelling can occur after major oral or neck surgery, airway protection is a priority and a tracheostomy may be needed. Postoperative nursing care focuses on airway and oxygenation monitoring, maintaining a patent airway, positioning to reduce swelling, careful wound and drain care, and strict aseptic technique. Nutrition support is critical because many patients already have poor intake before surgery, and healing demands adequate calories and protein. Enteral feeding is often used until swallowing improves, and the nurse monitors for aspiration risk, dehydration, and weight loss. Psychosocial support matters greatly because oral cancer and surgery can affect speech, swallowing, appearance, and self-image. Esophageal cancer commonly presents late because early symptoms can be subtle. The two main types are adenocarcinoma and squamous cell carcinoma. Historically, squamous cell carcinoma was strongly linked to tobacco and heavy alcohol use due to chronic mucosal irritation. In recent decades, chronic gastroesophageal reflux disease, GERD, has become a major contributor to adenocarcinoma, particularly through a precancerous condition called Barrett esophagus, where the lining of the esophagus changes due to repeated exposure to stomach acid. Patients diagnosed with Barrett esophagus may need periodic endoscopy and biopsy, especially if dysplasia is present, because monitoring can detect changes before cancer becomes advanced. A hallmark symptom is progressive dysphagia, meaning swallowing becomes increasingly difficult over time. Typically, patients first have trouble swallowing solid foods, then soft foods, and eventually liquids. Other possible symptoms include hoarseness, regurgitation, persistent cough, foul breath, and unintended weight loss. Pain often occurs later and may be felt behind the breastbone, in the upper abdomen, or radiating to the back, especially when swallowing. Diagnostic evaluation may include a barium swallow to identify narrowing, but definitive diagnosis is made with esophagogastroduodenoscopy, EGD, and biopsy. Imaging such as computed tomography Connecticut, or positron emission tomography may be used for staging. Treatment depends on stage and may include endoscopic removal of localized lesions, ablation therapies, chemoradiation, or surgical procedures such as esophagectomy with reconstruction. For advanced cancer, care may be palliative and focused on relieving dysphagia and improving quality of life, including dilation or placement of esophageal stents. Nursing management prioritizes a patent airway and adequate breathing, especially after major thoracic or abdominal procedures. Pain control, pulmonary hygiene, early ambulation when appropriate, and monitoring for complications are essential. Nutrition support is a major focus because dysphagia and treatment reduce intake and patients may require enteral feeding. When oral intake resumes, it typically begins with small amounts and advances slowly to small frequent meals, with the patient upright to reduce regurgitation and aspiration risk. A serious postoperative complication is an anastomotic leak. Signs can include fever, increased pain, dyspnea, tachycardia, and changes in vital signs. These require prompt provider notification. Another important nursing role is smoking cessation support. If a patient requests to smoke, the nurse should use a calm, non-judgmental approach, explain safety concerns and healing risks, and offer nicotine replacement options if ordered. A hiatal hernia occurs when part of the stomach pushes upward through the opening in the diaphragm where the esophagus passes. This opening is called the esophageal hiatus. When muscle tone weakens or intra-abdominal pressure increases, such as with obesity, pregnancy, ascites, or chronic coughing, the stomach can protrude into the thoracic cavity. There are two major categories. The most common type is a type 1 sliding hernia, where the gastroesophageal junction moves above the diaphragm. In paraesophageal hernias, types 2, 3, and IV, the fundus of the stomach or other abdominal contents move upward beside the esophagus. These are less common but more serious because they can become strangulated. Many patients have no symptoms unless reflux occurs. When gastric acid flows back into the esophagus, patients experience heartburn, indigestion, belching, epigastric or substernal pressure after meals, regurgitation of sour fluid, and nighttime coughing. Symptoms worsen when lying flat because gravity no longer helps keep gastric contents in the stomach. Diagnosis is usually made with an upper gastrointestinal series. Treatment focuses first on conservative measures. Weight reduction decreases intra-abdominal pressure. Patients should avoid tight clothing around the waist and avoid eating within 3 hours of bedtime. Elevating the head of the bed 6 to 8 inches allows gravity to help prevent reflux. Medications such as antacids, histamine 2 receptor antagonists, and proton pump inhibitors reduce acid exposure. Limiting caffeine, chocolate, alcohol, fatty foods, and smoking is essential because these relax the lower esophageal sphincter. Nursing management emphasizes patient education. Encourage upright positioning for at least 2 hours after meals. Teach use of a wedge pillow instead of stacked pillows, which flex the abdomen and worsen reflux. Reinforce medication timing and adherence. Remind patients to avoid heavy lifting and straining because these increase abdominal pressure and worsen herniation. The eighth image on the slide shows the procedure performed for the Nissen fundoplication surgery for hiatal hernia. This can also be used to treat gastroesophageal reflux disease, or GERD. In the case of hiatal hernia, this surgery is considered if symptoms are severe or bleeding occurs. Proton pump inhibitors, such as omeprazole and pantoprazole, suppress gastric acid more effectively by blocking the proton pump in parietal cells. These are commonly used for GERD and ulcer disease. They should not be crushed if delayed release. Long-term use may be associated with nutrient malabsorption and possible fracture risk, although evidence varies. Misoprostol prevents ulcers caused by nonsteroidal anti-inflammatory drugs, but is contraindicated in pregnancy. Sucralfate coats ulcers and must be taken separately from other medications. Antimicrobials such as clarithromycin, amoxicillin, tetracycline, and metronidazole are used in combination therapy for Helicobacter pylori infection. Antispasmodics reduce smooth muscle spasm but can cause anticholinergic side effects. Metoclopramide increases gastric motility but is not recommended for long-term use due to neurologic side effects. As LPNs, always assess for drug interactions, monitor renal and liver function when indicated, reinforce adherence, and teach patients to complete antibiotic regimens. Gastroesophageal reflux disease, or GERD, is a chronic condition caused by repeated reflux of stomach contents into the esophagus. It results from transient relaxation or weakness of the lower esophageal sphincter. Although many patients with GERD have a hiatal hernia, it is not present in all cases. Contributing factors include obesity, delayed gastric emptying, large meals, certain foods, and medications that relax the sphincter. Chronic acid exposure irritates the esophagus and may lead to esophagitis or Barrett esophagus. The most common symptom is heartburn, described as a burning sensation behind the sternum. Other symptoms include regurgitation, chronic cough, dysphagia, chest discomfort, bloating, and symptoms that worsen when lying down. Some patients experience nighttime coughing or asthma-like symptoms due to microaspiration or vagal reflex bronchospasm. Diagnosis is usually clinical based on symptoms. Endoscopy is performed if alarm symptoms such as weight loss, dysphagia, anemia, or bleeding occur. Esophageal manometry measures sphincter pressure and motility. 24-hour pH monitoring measures acid exposure. Treatment focuses on lifestyle changes and medication. Weight loss significantly improves symptoms. Patients should avoid late meals, caffeine, chocolate, alcohol, smoking, and high-fat foods. Elevating the head of the bed is helpful. Drug therapy may include antacids, H2 blockers, and proton pump inhibitors. Long-term proton pump inhibitor use may be associated with decreased magnesium and vitamin B12 absorption, although current evidence does not prove causation. Most experts agree that proton pump inhibitors are safe when used appropriately and monitored. As nurses, we monitor for symptom improvement, reinforce lifestyle changes, assess adherence, and educate about medication timing and side effects. When lifestyle modifications and medications such as proton pump inhibitors or histamine 2 receptor antagonists do not adequately control gastroesophageal reflux disease, more advanced therapies may be considered. Some patients benefit from endoscopic, minimally invasive procedures designed to improve lower esophageal sphincter, LES function. These procedures aim to reduce reflux without open surgery and are typically considered when symptoms persist despite optimal medical management. One common surgical option is laparoscopic fundoplication. In this procedure, the fundus, the upper portion of the stomach, is wrapped around the lower esophagus to strengthen the lower esophageal sphincter and create a new valve mechanism. This helps prevent gastric contents from refluxing into the esophagus. The most common version is the Nissen fundoplication, which involves a complete wrap. This same approach may be used in the repair of a hiatal hernia when one is present. Surgery is generally reserved for patients with severe chronic reflux, complications such as Barrett esophagus, or intolerance to long-term medications. However, fundoplication may be less effective in patients with severe obesity, and other bariatric procedures may be more appropriate in that population. As nurses, it is important to reinforce that surgery does not eliminate the need for lifestyle modification. Patients must continue dietary control, weight management, and follow-up care to maintain symptom relief. Patient education is the cornerstone of successful management of gastroesophageal reflux disease. Dietary modifications significantly reduce reflux episodes. Patients should avoid high-fat foods and spicy foods because fat delays gastric emptying and relaxes the lower esophageal sphincter. Eating 4 to 6 small meals instead of large meals prevents stomach overdistension, which increases reflux risk. Encourage patients to eat slowly and chew thoroughly. Avoiding straws and carbonated beverages reduces swallowed air and bloating, which can increase intra-abdominal pressure. Certain foods either increase acid production or relax the lower esophageal sphincter. These include caffeine, chocolate, peppermint, spearmint, alcohol, tomato-based products, citrus juices, and raw onions. Patients may benefit from keeping a food diary to identify personal triggers, as tolerance varies. Lifestyle changes are equally important. Patients should wait 2 to 3 hours after eating before lying down to allow gastric emptying. Tight clothing around the waist increases abdominal pressure and should be avoided. Weight reduction is one of the most effective interventions. Even a 10% decrease in body weight can significantly improve symptoms. Elevating the head of the bed 6 to 8 inches using blocks, not just pillows, uses gravity to reduce nighttime reflux. Smoking cessation is critical because nicotine relaxes the lower esophageal sphincter and stimulates acid secretion. Stress reduction techniques such as exercise, deep breathing, meditation, and relaxation can decrease symptom exacerbation. While stress does not directly cause GERD, it may worsen symptom perception and gastric acid production. Medication adherence is also essential. Patients should take prescribed medications at the correct time in relation to meals and bedtime to maximize effectiveness. As LPNs, reinforce these measures consistently, assess adherence, and evaluate whether symptoms are improving or worsening. Gastroenteritis is inflammation of the stomach and small intestine that usually occurs after exposure to contaminated food or water. It is most often infectious, meaning it can be caused by viruses, bacteria, or parasites. A very common cause is norovirus, which spreads easily in places like schools, long-term care facilities, and cruise ships. Other organisms that can cause gastroenteritis include Giardia and Shigella. It is important to clarify that Clostridioides difficile, C. Difficile most commonly causes infectious diarrhea after antibiotic exposure or healthcare exposure, rather than typical food poisoning, but it can still present with significant diarrhea and abdominal cramping. Patients typically develop rapid onset watery diarrhea, nausea, vomiting, abdominal cramping, and sometimes mild abdominal tenderness and bloating. Symptoms often last less than a week in otherwise healthy adults. However, fever, elevated white blood cell count, and stool that contains blood or mucus can occur, especially with more invasive bacterial infections. The biggest nursing concern is dehydration from fluid losses. Healthy adults often recover without hospitalization, but infants, older adults, pregnant patients, and chronically ill patients are at higher risk for dehydration and may require intravenous fluids to maintain circulation, kidney function, and electrolyte balance. When vomiting is active, keeping the patient nothing by mouth temporarily may be appropriate to prevent aspiration and reduce nausea. As soon as vomiting improves, the priority becomes rehydration. Oral rehydration solutions that contain the right balance of glucose and electrolytes are preferred because glucose helps the intestine absorb sodium and water more effectively. Drinks that are very high in sugar, such as many soft drinks and undiluted fruit juices, can worsen diarrhea by pulling water into the bowel. If diarrhea continues beyond several days, is severe, or includes blood, mucus, high fever, or signs of dehydration, stool studies may be ordered to identify the organism so that targeted treatment can be started. Rest, careful intake and output monitoring, skin protection, and symptom control medications may also be used, but medications for diarrhea should be used cautiously and generally avoided if the patient has bloody stool or suspected C. Difficile infection. Gastritis is inflammation of the stomach lining that can be acute or chronic. A major cause of chronic gastritis is Helicobacter pylori, H. pylori infection, which damages the protective lining of the stomach and increases the risk for peptic ulcer disease. Acute irritation of the stomach lining can also be triggered by alcohol, contaminated food, or certain medications. Non-steroidal anti-inflammatory drugs, such as aspirin and ibuprofen, are a very common cause because they reduce prostaglandins that normally protect the stomach lining. Corticosteroids can increase gastrointestinal risk, especially when combined with non-steroidal anti-inflammatory drugs, but they are not always harsh by themselves in the same way, so it is best to teach that the risk is higher with steroids plus other irritants. Cocaine can also decrease blood flow to tissues and contribute to gastrointestinal injury. Gastropathy is closely related but refers to damage to the stomach lining that may occur more from chemical injury than from classic inflammation. In real practice, symptoms can look the same: nausea, vomiting, epigastric pain, and loss of appetite, and endoscopy may not clearly distinguish the difference without biopsy. Untreated chronic irritation of the stomach lining can lead to ulcers and upper gastrointestinal bleeding, which can become life-threatening. Patients with gastritis may report anorexia, nausea, vomiting, epigastric pain or tenderness, hiccups, and sometimes diarrhea. Some patients with chronic gastritis may have minimal symptoms, but still be at risk for complications such as bleeding. Nursing priorities include monitoring for dehydration and electrolyte imbalance if vomiting is present, watching for signs of bleeding such as coffee ground emesis, black tarry stools, dizziness, or low blood pressure, and reviewing medication history carefully. Diagnosis is based on history, assessment, and endoscopy when indicated. Testing for H. pylori can be done by blood, stool, breath testing, or biopsy. Treatment depends on the cause. Acute gastritis is often short-lived and improves by removing the irritant, temporarily limiting oral intake if vomiting is severe, and using medications that reduce acid and protect the stomach lining. For chronic gastritis, patients may need acid suppression with a proton pump inhibitor or histamine 2 receptor antagonist, and antacids for symptom relief. If H. pylori is present, the patient is treated with a proton pump inhibitor plus antibiotics, commonly including amoxicillin and clarithromycin, with metronidazole used as an alternative in penicillin allergy. Education focuses on avoiding alcohol, stopping smoking, avoiding non-steroidal anti-inflammatory drugs when possible, and following diet adjustments that decrease irritation. For nutrition, a temporary progression from clear liquids to bland foods can reduce symptoms during recovery. However, the older BRAT-style approach can be used short-term, but patients still need adequate protein and calories as symptoms improve. The goal is gentle reintroduction of foods while avoiding greasy, highly seasoned foods, caffeine, and alcohol until fully recovered. A peptic ulcer is an open sore that forms in the lining of the stomach or the first part of the small intestine, called the duodenum. Ulcers develop when the protective mucus barrier cannot adequately defend the tissue against stomach acid and digestive enzymes, so the tissue becomes injured and erodes. In current practice, the two biggest causes are Helicobacter pylori, H, pylori infection, and nonsteroidal anti-inflammatory drug use such as ibuprofen, naproxen, and aspirin. Smoking increases risk and also slows healing. Stress does not usually cause chronic ulcers by itself, but long-term stress can worsen symptoms and health behaviors, and critical illness stress ulcers can occur in patients who are severely ill because blood flow to the stomach lining decreases and the protective barrier weakens. H. Pylori damages the stomach's protective lining and triggers inflammation, which makes the lining more vulnerable to acid and pepsin. It is more accurate to say H. Pylori produces urease, an enzyme that helps it survive in acid and contributes to inflammation and mucosal injury. Over time, chronic H. Pylori infection increases the risk for complications such as gastric cancer and a rare lymphoma called mucosa-associated lymphoid tissue lymphoma. Drug-induced ulcers are commonly linked to nonsteroidal anti-inflammatory drugs and aspirin, and risk increases when these medications are combined with alcohol, anticoagulants, corticosteroids, or a history of prior ulcer or gastrointestinal bleeding. In the image, you can see the locations for A, the gastric peptic ulcer, and B, the duodenal gastric ulcer. When you assess ulcer symptoms, focus on pain timing, bleeding signs, and risk factors. Ulcer pain is often described as burning or gnawing in the epigastric area and can come in waves. The pattern matters. Duodenal ulcer pain is classically relieved by eating and may return 2 to 3 hours after a meal or wake the patient at night, while gastric ulcer pain may worsen shortly after eating, which can cause patients to avoid food and lose weight. Patients may also report nausea, decreased appetite, or fatigue from anemia. Older adults may not show the typical pain pattern at all, so unexplained weakness, anemia, weight loss, dizziness, or vomiting can be the main clues. A major safety priority is identifying gastrointestinal bleeding early. Vomiting bright red blood can signal active bleeding, while coffee ground emesis suggests older blood that has been partially digested. Black tarry stools usually mean digested blood from an upper gastrointestinal source, but remember that iron supplements can darken stool and some foods can change stool color. With significant bleeding, patients may become pale, restless, thirsty, confused, and develop tachycardia and hypotension. Vital sign changes may not appear until a large blood loss has already occurred, so ongoing assessment is essential. Hemoglobin and hematocrit may look normal early in a bleed because fluid shifts take time, and blood urea nitrogen can rise because the body digests blood protein. Diagnosis is most often confirmed with esophagogastroduodenoscopy, which allows the provider to see the ulcer, obtain biopsy samples when needed, test for H. pylori, and treat bleeding directly. If bleeding is severe and difficult to control, angiography may be used to locate the source and deliver therapy. Testing for H. pylori can be done with biopsy during endoscopy, a urea breath test, stool antigen testing, or blood tests. In practice, blood antibody tests can stay positive even after the infection is gone, so they are not always the best choice for confirming an active infection. Treatment starts with medication and removing causes. Proton pump inhibitors are commonly used because they strongly suppress acid and promote healing. If H. pylori is present, the priority is eradication therapy, which combines acid suppression with antibiotics. For active bleeding ulcers, endoscopy may use thermal coagulation, clips, or injection therapy to stop bleeding, and patients may need intravenous fluids, blood products, and oxygen to support circulation and tissue oxygenation. As nurses, your role includes monitoring vital signs and symptoms closely, maintaining reliable intravenous access, measuring intake and output, assessing emesis and stool characteristics, and watching for ongoing or recurrent bleeding. Complications of peptic ulcer disease include hemorrhage, perforation, and obstruction. Perforation is a surgical emergency and can present with sudden severe abdominal pain, a rigid, board-like abdomen, tenderness, and signs of shock. Obstruction can occur when scarring narrows the pylorus and may present with persistent vomiting and abdominal distension. After gastric surgery, be cautious with any nasogastric tube because movement can disrupt sutures, and teach patients about dumping syndrome, which can cause nausea, cramping, diarrhea, sweating, and palpitations after meals due to rapid emptying into the small intestine. Small, frequent meals and avoiding concentrated sweets help reduce symptoms. During implementation and teaching, emphasize that most patients improve when they take medications exactly as prescribed, avoid nonsteroidal anti-inflammatory drugs unless directed, stop smoking, limit alcohol, and eat at regular intervals rather than skipping meals and then eating large meals later. Current guidance supports restricting only foods that trigger symptoms for that individual, but alcohol and caffeine often worsen symptoms and should be avoided during healing. Finally, documentation matters for patient safety, continuity, and legal protection. Record assessment findings, patient responses, and all follow-up actions clearly. Gastric cancer, also called stomach cancer, is often discovered late because early symptoms can be mild and easy to dismiss. Current estimates from the American Cancer Society for 2026 are about 31,510 new stomach cancer cases and about 10,740 deaths in the United States. So it remains a serious health problem even though it is not among the most common cancers. When stomach cancer is found early, outcomes are much better than when it has spread. Survival drops sharply once disease is regional or distant, which is why early recognition of concerning symptoms and timely follow-up matter. The exact cause is not always known, but we do know several important risk factors. Helicobacter pylori infection is a major risk factor because it can cause chronic inflammation and changes in the stomach lining over time, and it has been classified as a Group 1 carcinogen by the International Agency for Research on Cancer. Diet patterns can also matter, especially frequent intake of heavily salted, smoked, or preserved foods, while diets richer in fruits and vegetables are associated with lower risk in population studies. Tobacco use and heavy alcohol use increase risk as well, and pernicious anemia and long-standing low stomach acid states can be associated with chronic stomach lining changes that raise concern. As nurses, we translate this into practical prevention teaching. Encourage smoking cessation, moderation or avoidance of alcohol, safe food handling, and follow through with evaluation and treatment for H. pylori, when it is identified by the provider. Pathophysiology-wise, many gastric cancers begin in the glandular tissue of the stomach lining, and a common location is the lower portion of the stomach, the antrum or near the pylorus. Over time, the tumor can invade deeper layers of the stomach wall and spread through lymph channels to lymph nodes and to organs such as the liver. In females, metastasis can involve the ovaries, which is one reason unexplained abdominal symptoms and weight loss should never be brushed off. From a nursing lens, the key is to connect the why to assessment findings. Progressive fatigue, pallor, and weakness can reflect anemia from slow blood loss, and the patient may report vague indigestion, early fullness, nausea, vomiting, or unintended weight loss. Because symptoms can be nonspecific, diagnosis typically relies on imaging and direct visualization. An upper gastrointestinal series may show an abnormal area, but endoscopy with biopsy is the definitive way to diagnose gastric cancer and identify the tumor type. Laboratory testing often shows anemia on a complete blood cell count, and stool may be positive for occult blood. Tumor markers such as carcinoembryonic antigen or carbohydrate antigen 19 can be elevated, but they are not specific enough to diagnose gastric cancer on their own. They are more often used in monitoring. Computed tomography imaging is commonly used to help stage disease and plan treatment. Treatment depends on stage and the patient's condition. Surgery may be used to remove the tumor when possible, relieve obstruction, or reduce tumor burden. Lymph node removal may be included when cancer has spread locally. Chemotherapy and targeted therapies may be used based on tumor features. For example, some gastric adenocarcinomas have markers such as human epidermal growth factor, receptor 2, or vascular endothelial growth factor pathways that guide medication choices. Nursing management focuses heavily on supporting nutrition, managing symptoms, preventing complications, and promoting recovery after surgery, similar to care after other major abdominal procedures, while also monitoring for anemia, dehydration, poor intake, and intolerance to diet advancement. Patient teaching and emotional support are essential because the diagnosis is often made at a stressful and advanced point in the illness. Gastrointestinal decompression is used to relieve pressure caused by excess fluid or gas in the stomach or intestines. When abdominal distension occurs, pressure builds inside the abdominal cavity. This pressure is uncomfortable and can impair organ function. The diaphragm may be pushed upward, limiting lung expansion and contributing to shortness of breath. Increased intra-abdominal pressure can also affect circulation and delay gastrointestinal motility. As LPNs, it is important to understand that decompression is not just for comfort. It can prevent complications such as aspiration, bowel ischemia, or respiratory compromise. A nasogastric tube is commonly inserted to remove gastric contents, including fluids and gas. Nasogastric refers to the route of insertion through the nose into the stomach. However, the term nasogastric tube is generic. The type of tube selected depends on the purpose of therapy. A Levin tube is a single lumen tube used primarily for intermittent suction or medication administration. A Salem sump tube is a double lumen tube that includes an air vent, often called a pigtail, which helps prevent the gastric mucosa from being pulled into the suction openings. Intestinal tubes are longer and may be advanced beyond the stomach into the small intestine, often under fluoroscopic guidance. During decompression, continuous assessment is essential. Persistent abdominal distension, nausea, vomiting, feelings of fullness, increasing abdominal girth, or worsening shortness of breath suggest that decompression is not effective. These findings require prompt evaluation. As the nurse, you must verify that suction is functioning properly, that tubing connections are secure, and that the drainage container is positioned correctly. Excessive suction can cause trauma by pulling gastric mucosa into the tube's drainage openings, potentially leading to ulceration or bleeding. Unless otherwise ordered, low continuous suction, typically between 80 and 100 millimeters of mercury, is used for a Salem sump tube. Levin tubes generally function best with intermittent suction. Always verify the ordered suction type and setting. When caring for a patient with a Salem sump tube, the air vent must remain open to air and above the level of the stomach to prevent leakage of gastric contents. If leakage occurs from the pigtail, it can be cleared by instilling a small amount of air only. Fluids should never be instilled into the air vent. During ambulation, the main suction tubing may be disconnected and the primary lumen plugged as ordered, but the nurse remains responsible for ensuring the system is reconnected and functioning afterward. Irrigation with normal saline may be ordered to maintain tube patency. The volume instilled must be recorded as intake, and total drainage must be recorded as output. Accurate intake and output measurement is critical because continuous suction can lead to fluid and electrolyte imbalances, particularly metabolic alkalosis from loss of gastric acid. If the patient has had recent gastrointestinal surgery, irrigation should be performed using a septic technique to reduce infection risk. Drainage characteristics must be assessed and documented each shift. Green, yellow, brown, or clear secretions may be expected depending on location. Coffee ground-appearing material suggests possible bleeding and should be tested and reported. Unexpected bright red blood requires immediate notification of the healthcare provider. Nasogastric tubes are uncomfortable. Frequent assessment of the nares is necessary to prevent pressure injury. Common complaints include sore throat, dry mouth, nasal dryness, and ear discomfort due to eustachian tube irritation. Frequent oral care, lip lubrication, and humidified air can improve comfort. If allowed by the provider, ice chips, sugar-free hard candy, or chewing gum may help relieve dry mouth. After tube removal, the patient must be monitored closely for return of nausea, vomiting, abdominal distension, or inability to tolerate oral intake. In some cases, reinsertion may be necessary if symptoms recur.